I'm Dr. Sarah Mitchell, a neonatologist at Greenfield Children's Hospital, a place where the fragility of life meets the marvels of modern medicine every day. Our neonatal intensive care unit NICU is equipped with some of the most advanced life support technologies available, designed to give our tiniest patients a fighting chance when the odds seem insurmountable. Over the years, I have witnessed countless fragile newborns, some who fought fiercely and prevailed, others who slipped away despite our best efforts. Each day in the NICU is a delicate balance, a tightrope walk between hope and heartbreak. Greenfield Children's Hospital has earned a reputation not just for its cutting-edge technology, but also for its multidisciplinary approach, where neonatologists, nurses, respiratory therapists, and developmental specialists converge around each infant's bedside. We manage an array of complex conditions: premature lungs struggling to breathe, persistent infections, congenital anomalies, and myriad other challenges that threaten the earliest stages of life. Amidst the beeping monitors and the hum of ventilators, my team and I have learned that medicine is as much an art as it is a science, that the smallest lives can teach us the greatest lessons in resilience and fragility. In these halls, every newborn is more than a patient. They are a story unfolding in real time, a testament to the tenuous thread by which life hangs. I have cared for infants born at the cusp of viability, weighing less than a pound, whose tiny hearts fluttered with a will to survive that defied logic. The NICU is a place of miracles and mysteries, where the boundaries of what is possible are constantly tested. This is the environment where I met baby Noah, a newborn whose journey would challenge everything we thought we knew about neonatal medicine. Noah's arrival was marked by the usual flurry of activity that accompanies a high-risk delivery. He was born prematurely, his lungs barely developed, and his tiny body struggling to adjust to a world for which it was not yet ready. The moment he cried, a fragile, rasping sound, I felt the quiet determination that often accompanies the tiniest fighters. Yet, as I held him for the first time, I knew this would be no ordinary case. His skin was translucent, almost ethereal, and his breaths were shallow and irregular. The NICU team sprang into action, moving swiftly to stabilize him. At Greenfield, we pride ourselves on the seamless coordination between the delivery room and the NICU. For babies like Noah, minutes can make the difference between life and death. As the neonatology team received him, we immediately initiated respiratory support and began assessing the extent of his prematurity and complications. His initial blood work revealed the severity of his condition, markers of distress that told a story of organs struggling to function in a body that was still forming. Despite the precision of our interventions and the sophistication of our equipment, the fragile nature of his tiny physiology meant that every breath he took was a battle. The NICU environment around Noah was tense but focused. Monitors beeped steadily, intravenous lines delivered life-sustaining medications, and nurses maintained a vigilant watch. Each member of the team brought years of experience to bear, yet there was an unspoken understanding that this was a path fraught with uncertainty. Premature infants face an array of challenges: respiratory distress syndrome, intraventricular hemorrhage, infections, and more. The fragility of their condition means that even with the best care, outcomes can be unpredictable. As I observed Noah through the glass of his incubator, I reflected on the many infants who had come through these very wards before him. Some had left footprints on our hearts, their tiny fingers curling in our palms as we witnessed the miracle of survival. Others had taught us humility in the face of nature's merciless hand. Noah's case was already shaping into one that would test the limits of our knowledge and the depth of our hope. The NICU at Greenfield is a place where science and humanity intersect. Every decision we make is informed by the latest research and clinical guidelines, yet each case demands a personalized approach. With Noah, we were confronted with the stark reality of prematurity compounded by complications that threatened multiple organ systems. Our initial stabilization efforts, though precise and rapid, underscored the tenuous hold he had on life. The technology that surrounded him, ventilators calibrated to deliver the perfect breath, monitors tracking every heartbeat, was both a safety net and a reminder of his vulnerability. In the quiet moments between the flurry of clinical interventions, I found myself contemplating the paradox of neonatal care. These infants represent both the beginning of life and the most profound vulnerability. Their bodies are works in progress, fragile architectures that require not only medical expertise, but also an extraordinary amount of patience and compassion. The NICU is a place where families confront the unimaginable, the possibility of losing a child before they have truly had a chance to live. As a physician, my role extends beyond the clinical. It encompasses the emotional and psychological support for parents who find themselves thrust into a world of uncertainty and fear. Noah's parents were present throughout, their faces etched with worry and hope. I remember the way they held his tiny hand, searching for connection, for reassurance that their child's fight was not in vain. Their presence was a reminder of the human dimension of our work, the intersection of science and soul. For every intervention we performed, there was an unspoken promise to do everything within our power to nurture this fragile life, to honor the trust placed in us by those who loved him most. In this environment, the routine challenges of neonatal care take on a profound significance. The NICU team is accustomed to managing crises, apnea episodes, fluctuations in vital signs, the delicate titration of medications that can mean the difference between improvement and decline. Yet, each case carries its own unique narrative. Noah's story was just beginning, but the weight of the moment was palpable. His survival would depend not only on the technology and treatments available, but also on the interplay of countless physiological variables that remain, in many ways, a mystery. Greenfield's NICU is a place of relentless vigilance. The constant monitoring, the adjustments in ventilator settings, the administration of surfactant to open fragile alveoli, the careful management of fluids and nutrition, all these elements are integral to the care of premature infants. Yet, even with all these tools, the outcomes are never certain. The complexity of neonatal physiology means that what we observe is often a delicate dance between stability and collapse. In the case of Noah, every breath, every heartbeat was a testament to resilience in the face of overwhelming odds. As I stood by his bedside that first day, surrounded by the hum of machines and the quiet urgency of the team, I was reminded that neonatology is a field defined by hope tempered with realism. The NICU is a crucible where science, compassion, and determination converge. It is here that I have seen the smallest patients teach some of the most profound lessons about life. Its fragility, its tenacity, and its capacity to surprise us in ways we never imagined. Noah's admission to Greenfield's NICU marked the beginning of a journey that would challenge not only our medical expertise, but also our understanding of what it means to fight for life at its most vulnerable threshold. In the days ahead, we would confront situations that defied expectations, pushing the boundaries of neonatal medicine and forcing us to confront the limits of our knowledge. But in this moment, as the team worked tirelessly to stabilize him, I held on to the hope that this tiny, fragile infant could become one of the many stories of survival that define the spirit of our NICU. Noah was born several weeks prematurely, his arrival marked by a flurry of urgency and concern. From the moment he entered the world, his small frame betrayed the severity of his condition. His skin was delicate, almost translucent, and his chest rose and fell with shallow, uneven breaths that spoke to the immense struggle within. The initial assessment revealed a newborn fighting against the odds, not just premature, but burdened with complications that would soon reveal themselves to be far more complex than we had anticipated. He was immediately admitted to our NICU, a place where every second counts and every intervention is meticulously calibrated. The incubator that became his temporary home was surrounded by a constellation of machines, ventilators delivering carefully measured breaths, monitors tracking his heart rate and oxygen levels, and intravenous lines administering medications and nutrition. Despite the technological sophistication, the atmosphere was heavy with tension. Noah's condition was critical, and the team's focus was unwavering. From the outset, it was clear that Noah's challenges went beyond what we typically see in premature infants. His lungs, underdeveloped and fragile, struggled to maintain adequate oxygenation. Mechanical ventilation was initiated, but even with the most advanced support, his oxygen levels fluctuated unpredictably. His tiny heart, working tirelessly, showed signs of strain, and his skin took on a pale, mottled appearance that hinted at systemic distress. The complexity of his condition was compounded by the fact that multiple organ systems were showing signs of distress, a scenario that demanded constant vigilance and rapid adjustments in care. The first hours in the NICU were a whirlwind of activity. Respiratory therapists adjusted ventilator settings in response to arterial blood gases. Nurses monitored his fragile vital signs, and laboratory tests were ordered to assess the extent of organ involvement. Despite the coordinated efforts, Noah's condition remained precarious. The usual indicators of stability were elusive, replaced instead by a pattern of rapid deterioration that challenged even the most experienced among us. As we monitored him, it became apparent that Noah was not responding to standard interventions as expected. This was a heartbreaking situation, one that defied the clinical norms we rely upon to guide treatment. It was as though his tiny body was caught in a downward spiral, slipping further away despite our best efforts. The usual respiratory support protocols, nutritional strategies, and pharmacologic measures were met with limited success. Each test result, each change in his vital signs, underscored the severity of the crisis unfolding before us. The emotional weight on the team was palpable. Neonatology is a field where hope must be balanced with realism, and the line between life and death can be razor-thin. Noah's parents were understandably overwhelmed, their faces etched with a mixture of fear, hope, and exhaustion. They remained by his side, holding his hand, whispering words of love and encouragement in voices barely above a whisper. Their presence was a constant reminder of the stakes involved. This was not just a medical case, but a family's entire world hanging in the balance. Despite the gravity of the situation, the NICU team remained resolute. We revisited every aspect of Noah's care, consulting with specialists, revising treatment plans, and exploring every possible avenue to stabilize him. Yet, the pattern of rapid deterioration persisted. His oxygenation worsened, blood pressure dropped, and signs of multi-organ distress became increasingly evident. It was a scenario that no neonatologist wants to face. A newborn teetering on the edge, slipping through the cracks of even the most advanced medical interventions. The complexity of Noah's condition was a stark reminder of the limits of neonatal medicine. While we have made incredible strides in supporting premature infants, some cases reveal the fragility and unpredictability inherent in the earliest stages of life. Noah's situation was one such case, a profound challenge that forced us to confront the boundaries of what technology and medicine can achieve. It was a sobering experience, underscoring the humility required in our profession and the need for compassion in the face of uncertainty. Throughout these critical hours, the NICU was a hive of focused activity. Every monitor beeped with urgency, every member of the team moved with purpose. Yet beneath the clinical precision was a shared sense of helplessness, a recognition that sometimes, despite all efforts, nature has its own course. We documented every shift in Noah's condition, every intervention delivered, and every response observed, data that would later inform not only his care, but also broader discussions about managing such complex neonatal crises. Noah's case was quickly becoming more than a routine NICU admission. It was evolving into a rare and heartbreaking situation that defied the usual clinical expectations. The rapid progression of his multi-organ distress was unlike anything we had routinely encountered, and the usual protocols seemed insufficient. This prompted urgent multidisciplinary discussions, involving pediatric intensivists, cardiologists, and infectious disease specialists, all brought together to unravel the mystery of his deteriorating condition. As these consultations unfolded, we explored potential diagnoses that might explain the severity and rapid progression of Noah's symptoms. The differential was broad, from severe infection and inflammatory responses to rare genetic or metabolic disorders. Each possibility carried its own implications, and each demanded time-consuming, complex testing. Yet, time was a luxury we did not have. Noah's condition demanded immediate and decisive action, even as uncertainty clouded our understanding. The emotional toll on the family was profound. Watching their newborn slip further into distress, their hope wavered but never extinguished. They clung to the belief that their child's resilience would prevail, even as the medical reality grew increasingly grim. Their courage in the face of such adversity was a powerful reminder of the human spirit's capacity to endure, and it fortified our resolve as caregivers to do everything possible for Noah. In the midst of this turmoil, I found myself reflecting on the nature of neonatal critical care. It is a field where the smallest patients confront the greatest challenges, where life hangs in a delicate balance and the outcomes are often uncertain. Noah's admission embodied this tension, a fragile infant caught in the storm of physiological collapse, whose journey would push us to the edges of our knowledge and compassion. As the hours passed, the NICU team remained steadfast, continuously adjusting ventilator support, administering medications to support failing organs, and providing meticulous nursing care. Every intervention was a bid to stabilize Noah's faltering systems, to buy precious time for his body to recover. Yet, the rapidity of his decline was a stark reminder that in neonatal medicine, sometimes the most advanced technology and expertise are met with limits imposed by biology itself. Noah's admission to the NICU was not just a clinical event. It was the beginning of a profound and heart-wrenching journey. The fragile balance of his tiny body, the unyielding determination of his parents, and the relentless efforts of the medical team converged in a story that would challenge our understanding of neonatal illness and resilience. At this early stage, the path ahead was uncertain, marked by the daunting reality that despite all our advances, some newborns face battles that defy expectation and test the very limits of hope. Noah's diagnosis was sobering and immediate: severe respiratory failure compounded by multi-organ distress. His tiny lungs, underdeveloped and weakened by prematurity, were barely able to exchange oxygen effectively, leaving his body starved for the very element essential to life. The cascade of complications was swift and relentless. His heart struggling to maintain adequate circulation, his kidneys beginning to falter, and his metabolic balance teetering precariously. In the NICU, such a diagnosis demands rapid, decisive action, a coordinated deployment of every available resource to stabilize the infant and prevent irreversible damage. From the moment Noah was admitted, the medical team launched into a comprehensive critical care protocol. Mechanical ventilation was at the forefront, providing life-sustaining respiratory support as his immature lungs labored under the stress of disease. We used a ventilator strategy tailored to minimize further lung injury, carefully adjusting tidal volumes, pressures, and oxygen concentrations to strike a delicate balance between support and harm. The ventilator's rhythmic hiss and the steady rise and fall of Noah's chest became the backdrop of our vigil. In tandem with respiratory support, we initiated a regimen of medications designed to support his failing organs and address the underlying causes of his distress. Surfactant therapy was administered to improve lung compliance, a standard but vital intervention in premature infants with respiratory distress syndrome. Inotropes were given to bolster cardiac output, aiming to sustain blood flow to vital organs. Fluids and electrolytes were meticulously managed to avoid overload while ensuring adequate perfusion. Antibiotics were started empirically, covering for potential infections that could exacerbate his fragile state. Continuous monitoring was essential. Noah was connected to an array of devices: pulse oximetry tracking oxygen saturation, arterial lines measuring blood pressure in real time, and blood gas analyses guiding ventilator adjustments. Every parameter was scrutinized, every fluctuation noted and addressed. The nursing staff maintained relentless vigilance, adjusting ventilator settings, administering medications, and providing supportive care with an expertise born of countless hours at the bedside of critically ill neonates. Despite these aggressive interventions, Noah's condition remained volatile and precarious. His oxygen levels fluctuated unpredictably, sometimes dipping dangerously low despite maximal ventilatory support. The strain on his heart was evident in episodes of bradycardia and hypotension, signaling that his circulation was struggling to meet the body's demands. His kidneys showed signs of dysfunction, with rising creatinine levels and reduced urine output, complicating fluid management and increasing the risk of systemic toxicity. The interplay of these failing systems created a fragile, unstable equilibrium that required constant attention. The medical team held frequent discussions, reassessing treatment plans and considering additional therapies. We consulted with pediatric cardiologists to evaluate cardiac function and optimize hemodynamic support. Infectious disease specialists weighed in on antimicrobial strategies, given the heightened risk of sepsis in premature infants with multi-organ failure. Nutritionists collaborated to provide parenteral nutrition, carefully balancing the need for growth with the risks of metabolic derangements. Each specialist's input was vital, reinforcing the multidisciplinary nature of critical neonatal care. Throughout this intense period, the emotional toll on the family was profound. Noah's parents remained steadfast at his side, their hope intertwined with fear as they watched their son endure procedure after procedure. Their faces bore the exhaustion of long hours and the weight of uncertainty, yet they never wavered in their presence. I often found myself speaking with them quietly, explaining complex medical details in terms they could grasp, offering what comfort I could even when the prognosis was grim. Their resilience was a source of strength for the entire team, a reminder of the human stakes behind every clinical decision. As the hours stretched into days, the relentless nature of Noah's illness became increasingly apparent. The interventions that had initially stabilized him now seemed insufficient to halt the downward trajectory. His respiratory status deteriorated further, requiring escalating ventilatory support and adjustments to oxygen delivery. Episodes of hypotension became more frequent, necessitating increased doses of inotropes and careful fluid resuscitation. Signs of metabolic acidosis emerged, reflecting the body's struggle to maintain chemical balance amid failing organ systems. This critical phase underscored the brutal reality of neonatal multi-organ distress. In such cases, the body's interconnected systems falter in concert, each failure amplifying the next. The lungs' inability to oxygenate blood compromises cardiac function. Compromised circulation diminishes renal perfusion. Renal failure disrupts electrolyte balance, which in turn affects cardiac rhythm and muscle function. It is a vicious cycle, one that tests the limits of medical intervention and the resilience of the infant's physiology. Despite the severity of Noah's condition, the NICU team remained unwavering in our efforts. We employed advanced ventilatory modes, including high-frequency oscillatory ventilation, to optimize gas exchange while minimizing lung injury. Renal function was supported with careful fluid management and, when necessary, diuretics to mitigate fluid overload. We monitored neurological status closely, aware that prolonged hypoxia and metabolic instability could lead to brain injury. Every decision was weighed carefully, balancing potential benefits against the risks inherent in aggressive intervention. Amid these clinical challenges, I was struck by the profound dedication of the nursing staff. Their expertise and compassion translated into vigilant bedside care, adjusting ventilator settings at the first sign of distress, administering medications with precision, and providing the gentle touch and reassurance that even the smallest patients respond to. The NICU is a place where technology and humanity intersect, and it was this combination that formed the backbone of Noah's care. As Noah's condition continued to fluctuate, the question of prognosis loomed large. Premature infants with such severe multi-organ distress have a high risk of mortality and long-term complications. We prepared the family for the possibility that despite our best efforts, Noah might not survive or could face significant developmental challenges. These conversations are among the most difficult we have, requiring sensitivity, honesty, and empathy. The line between hope and realism is delicate, and maintaining that balance is essential to supporting families through the darkest moments. In the midst of this clinical storm, there were moments of quiet, brief windows where Noah's vital signs would stabilize, offering a glimmer of hope. These moments reminded us why we persevere in the face of such adversity. Each tiny improvement was celebrated, a testament to the infant's will to survive and to the relentless efforts of the medical team. Yet, the overarching picture remained one of grave concern, with the unpredictability of his course casting a shadow over every intervention. The complexity and severity of Noah's illness challenged not only our clinical skills but also our understanding of neonatal physiology. Cases like his highlight the limits of current medical knowledge and the need for ongoing research into the mechanisms underlying multi-organ failure in premature infants. They also underscore the importance of a holistic approach, one that addresses not only the biological aspects of illness, but also the emotional and psychological needs of families and caregivers. Despite the gravity of his condition, I remained committed to providing Noah with the best possible care, guided by evidence-based protocols and a deep respect for the fragility of his tiny body. Every breath he took, every heartbeat that persisted against the odds, was a reminder of the preciousness of life and the responsibility we bear as caregivers. The NICU is a place of relentless hope and unyielding effort, where each day is a struggle to preserve life at its most vulnerable. Noah's journey through severe respiratory failure and multi-organ distress was a crucible, a test of medical science, teamwork, and human resilience. As I stood by his incubator, surrounded by the hum of machines and the quiet determination of the team, I knew that this was only the beginning of a battle that would demand everything we had to offer. The path ahead was uncertain, fraught with challenges that would push the boundaries of neonatal care and the depths of our compassion. The moment Noah's vital signs flatlined is etched into my memory with a clarity that time cannot erode. It was a quiet, devastating pause in the relentless rhythm of the NICU. The monitors that had been beeping steadily suddenly fell silent, the ventilator's mechanical hiss ceased, and the fragile life we had been fighting for seemed to slip away in an instant. The room, once filled with the focused urgency of care, was overtaken by a heavy stillness, as if the very air had thickened with the weight of loss. At that moment, Noah was declared clinically dead. The declaration of death in the NICU is a moment that carries profound emotional weight, for the medical team, for the family, and for the fragile life that has just ceased. It is a finality that demands recognition, yet it leaves a chasm of unanswered questions and aching grief. I remember standing by Noah's bedside, feeling a mixture of sorrow, exhaustion, and an overwhelming sense of helplessness. Despite every intervention, every ounce of skill and compassion poured into his care, his tiny body had succumbed. In that quiet space, the medical team gathered, a circle of professionals bound by shared loss and the burden of responsibility. We had witnessed countless deaths in the NICU, yet each one feels uniquely devastating, especially when it involves a newborn whose life had barely begun. The protocols were followed meticulously, vital signs checked repeatedly, confirmatory assessments made, and the official pronouncement given with solemnity. The gravity of the moment settled over us like a heavy fog. For Noah's parents, the moment was incomprehensible. I recall their stunned silence, their faces etched with disbelief and heartbreak. They had spent days, perhaps weeks, clinging to hope, only to have it shattered in an instant. Their world had contracted to the confines of the NICU, centered entirely around their son's fragile existence. Now, faced with the reality of loss, they were thrust into a realm of grief that no parent should ever have to endure. The NICU, usually a place of constant activity and vigilance, was enveloped in a quietness that felt almost surreal. Machines were turned down, monitors silenced, and the bustle of care gave way to a respectful stillness. The nurses, doctors, and therapists who had tended to Noah with unwavering dedication allowed themselves a moment of pause, a brief respite to honor the life that had been, however brief, and to process the emotional toll of the loss. In the midst of this solemnity, preparations began for the withdrawal of life support, the formal process of ending interventions and allowing the family to say goodbye. This process is one of the most heart-wrenching aspects of neonatal care, a blend of medical protocol and compassionate support. It is a time when the clinical and the deeply personal intersect, requiring sensitivity and grace. The family was given space and privacy, with our team offering whatever comfort we could provide. Quiet words, gentle touches, and the presence that speaks louder than any words. The emotional resonance of this moment extended beyond Noah's immediate family. The entire NICU team felt the impact. The nurses who had spent hours by his bedside, the respiratory therapists who managed his ventilator settings, the physicians who had debated treatment plans and agonized over every decision. Each one carried their own burden of grief, a testament to the bonds formed in the crucible of critical care. The loss of a patient, especially one so young and vulnerable, reverberates deeply within the hearts of those who care. As the family began to process their grief, questions and reflections surfaced. How had we reached this point despite our best efforts? Were there signs we had missed? Could anything have been done differently? These questions are a natural part of the healing process for medical professionals and families alike. They speak to the profound complexity and unpredictability of neonatal illness, where even the most advanced interventions cannot always alter the course of nature. The moment of Noah's death also underscored the fragile line we walk in neonatal care, between life and death, hope and despair. It is a line that is often blurred, marked by moments of uncertainty and profound emotion. The NICU is a place where miracles can happen, but also where loss is an ever-present reality. This duality shapes the experiences of families and caregivers, forging bonds of empathy and resilience. Despite the finality of the clinical declaration, the emotional and psychological journey for Noah's family was just beginning. Grief in the NICU context is complex and multifaceted, often accompanied by feelings of guilt, anger, and profound sadness. Our team strives to support families through this process, providing not only medical care but also emotional and psychological resources. Social workers, chaplains, and counselors become integral to the support network, helping parents navigate the unfathomable pain of losing a newborn. In the hours that followed, the NICU team gathered once again, reflecting on the course of Noah's illness and the lessons learned from his care. These debriefings serve multiple purposes. They allow for clinical review and quality improvement, but also provide a space for emotional processing and mutual support among staff. The loss of a patient is never taken lightly. It informs our practice and deepens our commitment to the families we serve. The quietness that fell over the NICU in the wake of Noah's passing was a stark contrast to the usual cacophony of alarms, ventilators, and human voices. It was a moment of collective mourning, a shared recognition of the fragility of life and the limits of medicine. Yet within that silence was also a profound respect for the journey we had undertaken. The relentless efforts made, the hope that had been sustained, and the love that had surrounded this tiny life. For me, personally, moments like these are a humbling reminder of why I chose neonatology, to bear witness to the most vulnerable stages of life and to accompany families through their most profound moments of joy and sorrow. Noah's death was a painful chapter in this ongoing story, one that challenged my own resilience and compassion. It reaffirmed the importance of empathy, the need for support within the medical team, and the enduring impact of these experiences on all who are involved. As we began the process of supporting Noah's family through their grief, I was acutely aware of the delicate balance between professional detachment and human connection. Maintaining this balance is essential in the NICU, where the emotional stakes are so high. It is a space where clinical expertise must be matched by emotional intelligence, where every interaction carries meaning beyond the immediate medical context. The loss of Noah was not just a clinical event. It was a profound human tragedy that resonated deeply within the NICU community. It reminded us all of the preciousness and fragility of life, and the profound responsibility we carry as caregivers. In those quiet moments following his passing, the room held an unspoken promise: to honor his memory through continued dedication to the care of all the infants who would come after him. The gravity of that moment lingered long after the monitors fell silent. It shaped the conversations we had, the care we provided, and the way we held space for families facing similar journeys. Noah's passing was a stark confrontation with mortality at its most raw, a reminder that despite all advances in medicine, some battles are beyond our control. Yet, even in the midst of this despair, the NICU community found strength in solidarity and purpose. The shared experience of loss fostered a deeper commitment to the families we serve, a renewed resolve to push the boundaries of knowledge and care. It was a moment that underscored the essential humanity at the core of neonatal medicine, the recognition that every life, no matter how brief, leaves an indelible mark. 30 minutes after Noah was declared clinically dead, the NICU was still steeped in a heavy silence. Families whispered consolations, nurses exchanged quiet words of support, and I sat beside his incubator, reflecting on the immense sadness of the moment. Yet, it was in this quiet that subtle signs began to emerge, so faint they might have been dismissed as a trick of the senses. A barely perceptible rise and fall of his chest caught my eye. At first, I questioned my own observation. Was it possible? Was Noah making a faint, involuntary breath? I immediately called for the team. The room quickly refilled with the familiar urgency of neonatal care, but this time it was tempered with disbelief and cautious hope. Nurses and respiratory therapists gathered around, eyes fixed on Noah's fragile body. The ventilator remained off, the monitors silent. Yet there, amid the stillness, was a subtle movement, an almost imperceptible effort to breathe. We began a rapid reassessment, checking vital signs with renewed intensity. The pulse oximeter, which had lain dormant, flickered to life, registering a faint yet present oxygen saturation. The electrocardiogram, previously flatlined, now showed a weak but discernible heart rhythm. It was as though life was spontaneously returning, defying the clinical declaration made just minutes before. The mix of emotions in the room was palpable. Disbelief battled with hope, skepticism with cautious optimism. I felt a surge of adrenaline mixed with a profound sense of awe. Could this be a spontaneous return of vital signs, a phenomenon so rare it borders on the miraculous? The team moved swiftly but carefully, ensuring that every observation was accurate and that this was not a false alarm. We initiated immediate supportive measures, gently assisting Noah's breathing with non-invasive ventilation while monitoring his heart rate and oxygen levels closely. The subtle breaths grew slightly stronger, and the heart rhythm stabilized. It was as if Noah's tiny body was rallying, summoning strength from some deep reserve we did not understand. The monitors began to beep softly, signaling a fragile but undeniable return to life. This unexpected development sent ripples through the NICU. The usual clinical certainty was replaced by a humbling reminder that medicine, for all its advances, still encounters mysteries beyond explanation. The phenomenon of spontaneous return of vital signs after clinical death is exceptionally rare, especially in neonates. It challenged our understanding of death and the criteria used to determine it. As the team worked to support Noah, I found myself reflecting on the limitations of our diagnostic tools and the rigid definitions we rely upon. Clinical death, while grounded in physiological criteria, is not always a clear-cut event. The body's capacity for spontaneous recovery, even after apparent cessation of vital functions, speaks to the resilience embedded in human physiology, particularly in the youngest among us. The emotional atmosphere in the room was complex. Relief mingled with disbelief, joy tempered by caution. Noah's parents, who had been engulfed in grief moments earlier, were now caught in a whirlwind of renewed hope and confusion. Explaining the situation to them required delicacy and honesty, acknowledging the extraordinary nature of what was happening while tempering expectations with the realities of Noah's fragile state. The team rallied around this miracle, yet we remained vigilant. Noah's condition was still tenuous, and the risk of deterioration remained high. Our approach was cautious, balancing the excitement of recovery with the sobering awareness of the challenges ahead. Every breath he took, every heartbeat that steadied, was a victory, but the road to stabilization was just beginning. This moment also prompted immediate discussions among the medical staff about the protocols for declaring death and the potential need for reassessment in certain cases. We reviewed the timing of our observations, the criteria used, and the possibility of phenomena like Lazarus syndrome, where spontaneous return of circulation occurs after failed resuscitation. While extensively documented in adults, such occurrences are exceedingly rare in neonates, adding layers of complexity to clinical decision-making. The philosophical implications of Noah's revival were profound. It forced us to confront the boundaries between life and death, the certainty we place in medical definitions, and the humility required in the face of biological mysteries. For me personally, it was a reminder of the unpredictability inherent in medicine and the importance of maintaining hope even in the bleakest moments. As Noah's breathing effort strengthened, the NICU team mobilized all available resources to support his recovery. Respiratory therapists adjusted ventilator settings to transition him back to assisted breathing gently. Nurses monitored his vital signs with renewed intensity, ready to respond to any signs of distress. Physicians coordinated care plans that balanced aggressive support with the need to avoid further trauma to his fragile systems. Throughout this process, the spirit of collaboration and shared purpose in the NICU was evident. Every team member understood the gravity of the situation and the delicate balance between triumph and tragedy. The collective experience of witnessing Noah's unexpected return to life fostered a renewed sense of dedication and hope among us all. Noah's faint breathing efforts became stronger over the hours that followed. His heart rhythm stabilized, and oxygen saturation improved. The monitors, once silent, now provided a steady stream of data that guided our interventions. It was a slow, painstaking progression, marked by moments of fragility and resilience in equal measure. Amidst the clinical care, I remained deeply aware of the emotional journey unfolding for Noah's family. Their grief had been abruptly interrupted by this astonishing turn of events. Supporting them required not only medical expertise but also empathy and clear communication. We sought to prepare them for the uncertainty ahead, emphasizing that while this was a remarkable development, Noah's condition remained critical. This extraordinary experience underscored the unpredictable nature of neonatal life and death. It reminded us that even in the face of overwhelming odds, the human body, especially that of a newborn, can exhibit remarkable resilience. Noah's spontaneous return of breathing challenged our clinical assumptions and inspired a renewed commitment to vigilant, compassionate care. In the days that followed, as Noah's condition slowly improved, the NICU team continued to monitor him closely, aware that his journey was far from over. This experience became a powerful narrative within our unit, a testament to the mysteries that still exist at the frontier of neonatal medicine, and a reminder of the importance of never abandoning hope, even when the situation seems most dire. The rarity of Noah's spontaneous return of breathing after being declared clinically dead challenged the very foundations of our medical understanding. In neonatal medicine, the criteria for death are rigorously defined: absence of heartbeat, cessation of respiration, and unresponsiveness forming the pillars upon which we base such solemn declarations. Yet, Noah's faint breathing and return of cardiac activity forced us to confront the limitations of these criteria and acknowledge the gray areas that exist at the edge of life and death. In the days following this unexpected revival, I found myself immersed not only in the clinical management of Noah's fragile condition, but also in deep reflection on the boundaries of physiology and the definitions we rely on. Medicine operates within frameworks designed for clarity and certainty, but cases like Noah's reveal the nuances and exceptions that defy easy categorization. The phenomenon of spontaneous return of circulation and respiration after apparent death, sometimes referred to as Lazarus syndrome, is documented in adult medicine, but in neonatology, it remains scarcely understood and exceptionally rare. Our team engaged in thorough discussions about potential physiological explanations. Could residual brainstem activity have persisted longer than expected, allowing for delayed resumption of respiratory effort? Was there an unrecognized delay in the cessation of cellular functions at the tissue level? These questions highlighted the intricacies of neonatal physiology, where the immature nervous and respiratory systems may behave unpredictably under extreme stress. The limitations of our diagnostic tools became evident in this context. Standard monitoring devices measure electrical and mechanical functions, but they cannot fully capture the complex biochemical and neurological processes occurring at a cellular level. The distinction between irreversible death and reversible cessation of function is sometimes less clear-cut than textbooks suggest. Noah's case was a vivid reminder that biology often resists neat definitions. Emotionally, the experience was as challenging as it was enlightening. For me and my colleagues, it underscored the necessity of humility in clinical practice. Despite years of training and experience, the mysteries of the human body, especially in its earliest and most delicate stages, can surprise even the most seasoned clinicians. The line between life and death is a delicate one, fraught with uncertainty, and requires a compassionate acceptance of the unknown. The philosophical implications weighed heavily on my mind. What does it mean to declare death when the body itself may still harbor the potential for revival? How do we reconcile clinical criteria with the unpredictable resilience of life? These questions are not merely academic. They influence how we counsel families, make clinical decisions, and frame our understanding of mortality. Throughout this period, the NICU team grappled with these uncertainties while continuing to provide meticulous care. We remained vigilant for any signs of neurological impairment or systemic instability that might inform our prognosis. Neurological examinations, imaging studies, and continuous monitoring were employed to assess the extent of any potential brain injury resulting from the period of apparent death. Remarkably, Noah showed no immediate neurological deficits despite the prolonged interval without breathing. This absence of overt damage deepened the mystery. It suggested that some protective mechanisms might have been at play, perhaps a degree of hypothermia, metabolic suppression, or yet unidentified physiological processes that preserved neural integrity during the crisis. The multidisciplinary consultations that followed were invaluable. Neurologists, neonatologists, ethicists, and other specialists collaborated to interpret Noah's condition and to consider the broader implications for neonatal care. These discussions extended beyond clinical parameters to encompass ethical considerations about death declarations, resuscitation efforts, and end-of-life care in neonates. Noah's case sparked important conversations within our institution about protocols for declaring death and managing extraordinary events like spontaneous revival. Should observation periods be extended in certain cases? What safeguards can ensure accuracy while respecting the emotional toll on families and staff? These questions prompted a reevaluation of existing guidelines and highlighted the need for ongoing research. The emotional journey for Noah's family was complex and profound. The initial grief of loss was suddenly transformed into cautious hope, then tempered by uncertainty about the future. Supporting them required delicate communication, balancing honesty about the unknowns with encouragement derived from Noah's resilience. The family's strength and openness to this uncertain path were remarkable, and their trust in our care was both humbling and motivating. For the medical team, Noah's experience was a profound lesson in the unpredictability of life and the importance of maintaining both scientific rigor and compassionate flexibility. It reinforced that while protocols and guidelines are essential, they must be applied with an awareness of individual variation and the possibility of exceptions. This period also highlighted the psychological impact on caregivers. Witnessing such a rare and inexplicable event stirred a mix of awe, hope, and professional introspection. It reminded us that medicine is not merely a technical endeavor but a deeply human one, where science meets mystery and where care extends beyond the body to touch the soul. Noah's spontaneous revival became a quiet catalyst for change within our NICU. It inspired a renewed commitment to vigilance, to questioning assumptions, and to embracing the complexity inherent in neonatal care. It also strengthened the bonds within our multidisciplinary team, fostering open dialogue and shared learning. As we continued to care for Noah, the balance between hope and caution remained delicate. While his return of life signs was extraordinary, his condition was still precarious, and the risk of complications persisted. Our approach was one of cautious optimism, celebrating each sign of improvement while preparing for the challenges that lay ahead. In reflecting on this experience, I was reminded that neonatology is a field defined not only by cutting-edge technology, but by the profound mysteries of life's beginnings. Noah's case illuminated the limits of our knowledge and the depths of resilience that can exist within the smallest bodies. It underscored the necessity of humility, compassion, and a willingness to embrace uncertainty. Ultimately, Noah's unexpected return of breathing after being declared dead challenged us to rethink the boundaries of medical definitions and to honor the complexity of life and death. It was a moment that transcended clinical practice, touching on the very essence of what it means to be human and to care for the most vulnerable among us. As Noah's breathing gradually strengthened, the atmosphere in the NICU shifted from one heavy with sorrow to a cautious but palpable sense of hope. His tiny chest, once motionless, began to rise and fall with increasing regularity, and his heart's rhythm settled into a steadier beat without the need for external electrical stimulation. It was a delicate transformation, a slow and fragile recovery that unfolded moment by moment, breath by breath. The medical team rallied quickly to support this miraculous revival. We transitioned Noah to non-invasive ventilation, carefully titrating the pressure and oxygen to ease the work of his lungs while avoiding further injury. Respiratory therapists monitored his gas exchange meticulously, adjusting ventilator settings in real time. Nurses maintained vigilant observation, ensuring that every shift in his condition was noted and addressed without delay. This coordinated effort underscored the essence of NICU care: precision, collaboration, and unwavering attention to the smallest details. Throughout this gradual stabilization, we remained acutely aware of Noah's vulnerability. His lungs, already compromised by prematurity and the preceding respiratory failure, were at risk of further damage from both mechanical ventilation and the underlying disease process. Our approach balanced aggressive support with gentleness, aiming to nurture his fragile pulmonary tissues back toward function without provoking additional trauma. Noah's cardiovascular status also showed signs of improvement. Inotropes were carefully tapered as his heart regained strength, and blood pressure stabilized within a safer range. Renal function, monitored through urine output and laboratory markers, began to normalize, indicating a tentative recovery of organ systems that had been severely stressed. It was a slow, painstaking process, marked by small victories that nonetheless felt monumental given the gravity of his prior condition. The team's collective spirit was buoyed by these signs of progress. The NICU, which had been steeped in grief and uncertainty just hours before, now buzzed with quiet optimism. Yet, this optimism was tempered by the sobering knowledge that Noah's journey was far from over. The road to recovery for an infant who had endured such profound physiological insult is long and fraught with potential setbacks. As days passed, Noah's vital signs stabilized further. His spontaneous breathing efforts increased in strength and frequency, allowing us to gradually reduce mechanical support. The monitors, once a source of alarm and tension, now reflected more stable parameters. Each improvement was met with a collective sigh of relief from the team, a momentary pause to acknowledge the resilience of this tiny life. The NICU environment, familiar with the fragility of premature infants, embraced this slow recovery with renewed dedication. Nurses, accustomed to the delicate dance of balancing support and protection, continued their vigilant care with empathy and expertise. Respiratory therapists adjusted oxygen delivery and ventilation modes as Noah's lungs adapted, always mindful of the balance between necessary intervention and the risk of injury. Physicians reevaluated Noah's care plan daily, integrating new data from blood gases, imaging, and clinical assessments. Multidisciplinary meetings included input from neonatologists, cardiologists, neurologists, and nutritionists, all focused on optimizing his recovery trajectory. This collaborative approach ensured that every aspect of Noah's complex condition was addressed holistically. Amid the clinical efforts, the emotional landscape of the NICU shifted as well. Noah's parents, who had endured the roller coaster of despair and hope, found a measure of reassurance in these steady improvements. Their presence at his bedside was a constant source of strength, their quiet encouragement and gentle touch reinforcing the human connection that underpins all healing. Supporting the family remained a priority. We communicated openly about Noah's progress, emphasizing both the positive signs and the ongoing risks. The balance between hope and caution was delicate. It required sensitivity to the family's need for reassurance without fostering unrealistic expectations. Our goal was to foster trust and partnership, ensuring they felt included and informed every step of the way. Noah's recovery became a quiet celebration within the NICU. The staff, who had witnessed the depths of his crisis, found renewed inspiration in his resilience. His case became a testament to the power of vigilant, compassionate care and the remarkable capacity for healing that can reside even in the smallest and most fragile patients. Yet, as we celebrated these milestones, we remained vigilant for potential complications. Premature infants recovering from severe respiratory failure are at risk for conditions such as bronchopulmonary dysplasia, pulmonary hypertension, and neurodevelopmental impairments. Monitoring for these outcomes required ongoing assessment and readiness to intervene as needed. The slow and steady improvement in Noah's condition also allowed for the initiation of supportive therapies aimed at promoting growth and development. Nutritionists worked closely to optimize his caloric intake, balancing the need for adequate nutrition with the limitations imposed by his fragile digestive system. Physical and occupational therapists began gentle interventions to support neuromotor development, mindful of the delicate balance between stimulation and rest. Throughout this period, the NICU team's commitment to family-centered care remained steadfast. We encouraged Noah's parents to participate in his care as much as possible, fostering bonding through skin-to-skin contact when feasible and involving them in routine care activities. This engagement was vital not only for Noah's emotional well-being, but also for empowering his family during an uncertain and stressful time. Noah's case became a poignant reminder of the unpredictable nature of neonatal medicine. His miraculous revival and subsequent gradual recovery challenged our assumptions and reinforced the importance of hope tempered by clinical vigilance. It also highlighted the remarkable resilience that can exist within the tiniest patients, a resilience that demands our utmost respect and dedication. As we continued to support Noah's recovery, I often reflected on the intricate interplay of factors that had brought him back from the brink. It was a convergence of physiological capacity, advanced medical interventions, and the unwavering commitment of a multidisciplinary team. This experience deepened my appreciation for the complexities and mysteries of neonatal care. Noah's journey was far from over, but the progress he made during this critical phase inspired all of us. It was a testament to the relentless efforts of the NICU team and the extraordinary potential for healing in the face of profound adversity. In the quiet moments by his bedside, I felt a renewed sense of purpose and hope, reminded once again why I had devoted my career to caring for the most vulnerable lives. As Noah's condition gradually stabilized, we embarked on a comprehensive and continuous monitoring process to assess the extent of any neurological injury resulting from his prolonged period without breathing. The fear with such episodes is always the potential for devastating brain damage due to hypoxia, and in neonates the consequences can be lifelong and profound. Yet, against all expectations, Noah demonstrated remarkable neurological resilience. Initial examinations revealed no obvious deficits, no seizures, no abnormal muscle tone, and reflexes appropriate for his gestational age. This absence of immediate neurological impairment was both surprising and cautiously encouraging. To deepen our understanding, we employed a battery of assessments, including cranial ultrasounds and, when Noah's condition allowed, magnetic resonance imaging (MRI) of the brain. These imaging studies aimed to detect subtle signs of injury, areas of ischemia, hemorrhage, or swelling, that might not be apparent on clinical examination alone. The results were reassuring. While there were some expected changes related to prematurity, there was no evidence of the severe hypoxic ischemic injury we had feared. This finding fueled hope that Noah's brain had somehow been protected during the critical period of respiratory arrest. The rarity of such an outcome prompted extensive multidisciplinary consultations. Neurologists, neonatologists, radiologists, and rehabilitation specialists came together to discuss Noah's case in detail. The consensus was one of cautious optimism tempered by the recognition that the full extent of neurological function would only be clear with time. Neonatal brains are extraordinarily plastic, and while early signs were promising, ongoing developmental assessments would be essential to monitor for any emerging deficits. This collaborative approach extended to exploring potential explanations for Noah's extraordinary recovery. The team considered rare conditions such as Lazarus syndrome, the spontaneous return of circulation after failed resuscitation, as well as possible protective physiological mechanisms that might have mitigated brain injury. Hypothermia, either accidental or induced, is known to reduce metabolic demand and protect neural tissue, but there was no evidence that Noah had experienced therapeutic hypothermia. Instead, discussions turned to the possibility of inherent individual variability in resilience and the threshold for reversible injury. The case also sparked broader conversations about the protocols for declaring death and managing resuscitation attempts in neonates. Given Noah's spontaneous revival, questions arose about observation periods following the cessation of life-sustaining measures and the criteria used to confirm death. While current guidelines are based on the best available evidence, Noah's experience highlighted the need for flexibility and individualized consideration in extraordinary cases. Ethical deliberations accompanied these clinical discussions. The NICU team, in collaboration with the hospital's ethics committee, examined the implications of prolonged resuscitation efforts, the balance between aggressive intervention and quality of life, and the communication strategies employed with families facing such uncertain prognosis. Noah's case underscored the importance of transparency, shared decision-making, and compassion in navigating these complex situations. Throughout this period, the emotional landscape for Noah's family was complex. The initial despair of loss gave way to cautious hope, then to a renewed sense of uncertainty about the future. Supporting the family required ongoing, sensitive communication, addressing not only the medical facts but also the psychological and emotional challenges they faced. Social workers and counselors became integral members of the care team, providing resources and guidance to help the family cope with the roller coaster of emotions inherent in such a journey. Meanwhile, Noah's medical care remained comprehensive and multidisciplinary. Beyond neurological assessments, we continued to monitor and support his respiratory and cardiovascular systems, ensuring that his recovery was holistic. Nutritionists tailored his feeding plans to promote growth while minimizing metabolic stress. Physical therapists introduced gentle interventions to encourage motor development, always mindful of his fragile state. The NICU environment, ever attuned to the needs of critically ill infants and their families, adapted to provide ongoing support tailored to Noah's unique situation. The experience brought the team closer together, fostering an atmosphere of shared learning and mutual support. Noah's case became a catalyst for reflection on the limits of medical knowledge and the mysteries that persist in neonatal care. As weeks turned into months, Noah's progress continued to be monitored with increasing detail. Developmental milestone assessments were initiated, tracking his cognitive, motor, and social skills against established norms. While early indicators remained positive, the team remained vigilant for subtle signs that could inform early intervention strategies if needed. Noah's extraordinary survival and recovery also inspired academic interest. Case reviews were prepared for presentation at neonatal conferences, aiming to share insights and provoke discussion within the broader medical community. His story underscored the need for continued research into the mechanisms underlying neonatal resilience and recovery from critical illness. The experience also prompted us to revisit our protocols for family support during and after critical events. Recognizing the profound psychological impact of such medical crises, the NICU team emphasized the integration of mental health services and peer support programs. Providing families with comprehensive care that addresses both physical and emotional needs became a central focus. In reflecting on Noah's ongoing journey, I was struck by the interplay of chance, biology, and compassionate care that had shaped his path. His case was a testament to the resilience of life and the profound mysteries that still challenge our understanding. It reminded me that neonatal medicine is as much about hope and humanity as it is about technology and science. Noah's story continues to unfold, a living narrative of survival against staggering odds. His recovery has reshaped our approach to care, deepened our appreciation for the limits and possibilities of medicine, and reinforced the essential role of empathy in every clinical encounter. As we move forward, we carry with us the lessons learned from this remarkable infant whose fragile life defied expectation and inspired us all. Noah's extraordinary journey soon captured the attention of the neonatology community beyond the walls of our NICU. Word of his spontaneous revival and remarkable recovery spread through professional networks, prompting discussions at conferences, case study presentations, and academic publications. His story became more than just a clinical anomaly. It evolved into a profound example of the uncertainties that define neonatal medicine and the resilience that can emerge from the most fragile beginnings. Within the broader medical community, Noah's case served as a powerful teaching point. It challenged established assumptions about the finality of death declarations in neonates and underscored the need for cautious humility when confronting the unknown. Trainees and seasoned practitioners alike found themselves revisiting protocols and reflecting on the delicate balance between medical intervention and respect for the natural course of life. Noah's case became a catalyst for dialogue about the boundaries of life-sustaining treatment and the ethical complexities inherent in neonatal care. The narrative of Noah's survival resonated deeply because it illuminated the unpredictable nature of neonatal physiology. His story became a living testament to the fact that, despite advances in technology and knowledge, there remain mysteries in how tiny, developing bodies respond to extreme stress and injury. It highlighted the limitations of our current diagnostic tools and the potential for unknown biological mechanisms to influence outcomes. Beyond the clinical and academic realms, Noah's journey offered a profound lesson in humility and vigilance. It reminded the neonatal community that every infant is unique, and that protocols, while essential, must be applied with sensitivity to individual circumstances. His case reinforced the importance of maintaining an open mind and a willingness to adapt care plans in response to unexpected developments. Noah's story also touched on the emotional and psychological dimensions of neonatal care. It brought to light the profound impact that uncertainty and hope have on families and caregivers. His survival became a beacon of inspiration for parents navigating the daunting landscape of premature birth and critical illness. It emphasized the need for compassionate communication, family-centered care, and the integration of psychosocial support throughout the NICU journey. In our institution, Noah's case prompted reflective practice and quality improvement initiatives. It encouraged the development of guidelines that incorporate flexibility in death declarations and resuscitation protocols, acknowledging the rare but significant possibility of delayed spontaneous revival. This institutional learning fostered a culture that balances scientific rigor with empathy and adaptability. Moreover, Noah's experience influenced educational curricula for healthcare professionals. Training programs began to include discussions on the ethical, physiological, and emotional complexities illustrated by his case. It became a cornerstone example in teaching the importance of interdisciplinary collaboration, critical thinking, and compassionate care in neonatology. Noah's survival story also reached beyond medical circles, resonating with the public and advocacy groups focused on neonatal health. It sparked conversations about the value of research into neonatal resilience, the importance of supporting families during critical care, and the need for policies that reflect the nuanced realities of life and death in the NICU. His journey became part of a broader narrative advocating for advances in neonatal medicine and family support services. Reflecting on Noah's impact, it was clear that his case had reshaped perspectives not only on clinical practice but also on how we approach the human experience of neonatal illness. It underscored that medicine is not solely about curing, but also about accompanying families through uncertainty, celebrating resilience, and honoring the fragile beauty of life. For me personally, Noah's story deepened my commitment to fostering a culture of humility and vigilance in my practice. It reinforced the necessity of listening, not just to monitors and test results, but to families, to colleagues, and to the subtle cues that might signal something beyond the expected. His case became a touchstone for the profound responsibilities we bear as caregivers to the most vulnerable. Noah's journey also highlighted the importance of storytelling in medicine. Sharing his experience allowed for collective learning, emotional processing, and the forging of connections across disciplines and institutions. It reminded us that behind every clinical chart is a human story, rich with complexity and meaning. As the neonatology community continues to grapple with the challenges inherent in caring for fragile newborns, Noah's case stands as a reminder of the delicate interplay between knowledge and uncertainty. It calls us to approach each patient with both scientific rigor and profound compassion, recognizing that the course of illness and recovery can defy even the most carefully constructed expectations. Noah's story has become woven into the fabric of neonatal care at Greenfield Children's Hospital and beyond. It informs how we train future clinicians, how we conduct research, and how we support families facing the most difficult of circumstances. His legacy is one of resilience, hope, and the enduring mystery of life's beginnings. In witnessing Noah's journey, I have come to appreciate more deeply the sacred trust placed in us as neonatologists. Our work is not only about survival but about honoring the fragile, unpredictable dance between life and death. Noah's survival, against all odds, continues to inspire and challenge us to do better, to learn more, and to care more deeply. His story is a testament to the human spirit, both in the infant who fought to live and in the community of caregivers and loved ones who stood unwaveringly by his side. It reminds us that in neonatology, every life, no matter how brief or fragile, holds profound significance and the potential to teach us invaluable lessons about medicine and humanity. After weeks of intensive care, Noah's condition improved enough to consider discharge from the hospital, a milestone that felt almost surreal given the gravity of his early struggles. Watching him, now stronger and more responsive, preparing to leave the NICU was a moment filled with profound emotion for our entire team. His survival story had become woven into the very fabric of our daily work, a living testament to resilience and the power of vigilant, compassionate care. Noah's discharge was not a simple conclusion, but rather a transition into a new phase of careful monitoring and developmental support. We equipped his parents with detailed guidance on home care, follow-up appointments, and early intervention services. The multidisciplinary team, including pediatricians, therapists, and social workers, collaborated to create a comprehensive plan tailored to support Noah's ongoing growth and well-being outside the hospital's walls. The impact of Noah's survival extended far beyond his immediate family. Within our NICU, his case had transformed the way we approached care, reinforcing the importance of never giving up too soon and maintaining hope even in the darkest moments. His journey inspired a collective commitment to vigilance, empathy, and continuous learning among staff, fostering an environment where every infant's potential is honored and nurtured. For me personally, Noah's story reshaped my perspective on the fragility and resilience of life. It deepened my appreciation for the delicate balance we navigate as clinicians, balancing scientific rigor with the unpredictable nature of human physiology. His survival reaffirmed the necessity of compassionate care that embraces uncertainty and supports families through the complexities of neonatal illness. Noah's case became a beacon within the medical community, reminding us that behind every monitor and test result lies a unique human story filled with hope, struggle, and the possibility of unexpected triumph. It underscored the profound responsibility we bear to approach each patient holistically, recognizing the interplay of medical science and the human spirit. As I reflect on Noah's journey, I am reminded of the countless families who walk through the NICU doors each day, carrying hopes and fears that mirror those of his parents. Their resilience and trust fuel our dedication to providing the best possible care, even when outcomes are uncertain. Noah's story serves as a powerful reminder that in medicine, hope is both a guiding light and a precious gift. The lessons learned through Noah's case continue to influence our protocols, educational programs, and family support services. They inspire ongoing research into neonatal physiology and recovery, pushing the boundaries of knowledge while honoring the mysteries that still elude us. His survival encourages us to embrace humility and curiosity in equal measure. Noah's discharge marked a beginning rather than an end, a continuation of his remarkable journey, supported by a community committed to nurturing his potential. The courage and determination he demonstrated inspire all who have cared for him and those who will encounter similar challenges in the future. In the quiet moments after his discharge, I often think about the fragile yet enduring nature of life. Noah's survival story embodies this paradox, illustrating how the smallest patients can teach the most profound lessons about resilience, hope, and the human capacity to overcome adversity. His journey has left an indelible mark on my practice and my heart. It reminds me daily that medicine is as much about honoring the mysteries of life as it is about applying science. Noah's fragile breath, once so precarious, now carries with it the enduring spirit of survival that defines our work as caregivers. As we continue to follow his progress beyond the hospital, Noah's story remains a beacon of hope and a testament to the extraordinary resilience found in the tiniest lives. It challenges us to never lose sight of the possibilities that exist even in the face of overwhelming odds, and to approach every patient with unwavering compassion and dedication. In the end, Noah's survival is more than a medical triumph. It is a celebration of life's unpredictability and the profound impact of human connection in the journey of healing. His story will continue to inspire and guide us, reminding us that in the delicate balance between fragility and strength, hope endures.